Hello, good evening, good afternoon, good morning to everyone today, wherever you are tuning in from. Welcome to Neurology for Vets Facebook Live Journal Club. This is sponsored by Hallmark Veterinary Imaging, so thanks to Hallmark for supporting us. During these sessions, we invite a rising star of the profession to talk about one of their recently published studies, and today we're in for a treat as we get to hear about two recently published studies on the similar theme: spinal arachnoid diverticula in cats and a similar study in dogs. So it's time to compare and contrast. But first, let's introduce our speaker. We are very honored and happy to welcome Dr. Jaoa Miguel De Frias. Hopefully I did that right. Joao qualified from the University of Trás-os-Montes e Alto Douro. For those of you who don't know, because they didn't understand my Portuguese, that's in Portugal, in Porto, and he graduated in 2014. Now we got that bit out of the way, because usually I mess that up. Continuing with your introduction, Joao, he followed a rotating internship and a neurology internship in the UK private referral hospital. And he undertook a ECVN residency at the Royal Veterinary College in London. So say hi to everybody at the RVC. He is an RCVS and EBVS recognized veterinary specialist in neurology since last March, and currently is a lecturer of veterinary neurology and neurosurgery at the Royal Dick School of Veterinary Studies, University of Edinburgh, my alma mater. And so say hi to everybody at the team there. And welcome, Joao. Hopefully I didn't butcher your name and university. But welcome. Thanks very much for coming. And I'm going to hand over to you.
Thank you very much, Simon. Good evening, everyone. Let me just pull up presentation and we take things from there. Just having. All right.
Perfect.
Is it working? Perfect. Here we go. So yeah, welcome everyone. It's a pleasure to be here on this journal club. Today we'll be developing on this hopefully exciting journey about spinal arachnoid diverticula in dogs and cats. We'll focus on these two, recent last year's paper that we have published, and we'll just delve into the results and looking for your questions. So first of all, we'll go through dogs and this question that came up on diagnostic imaging rotation while I was just reporting some MRIs. And is the confirmation clinically relevant? I've just noticed that this teardrop shape was different in two cases from that week. As we know, the pathophysiology of SADs is not completely understood, and as more and more that we look into it, as more I think that there is a spectrum from congenital ones for acquired ones, and even like this type of cysts of diverticulum maybe just different. There's a lack of descriptions of variations SAD in dogs and how this can be relevant. And in humans, as you can see on those examples on your right side, there is difference in the DOM cape conformation. And then you can see these white arrows also highlighting some changes on the spinal cord, which are related to this conformation. So the aims of this study were to describe the variations of SAD, first of all, and then to identify if there was any association between SAD conformation and anything related to signalement or the imaging findings, including the presence of syringomyelia or concurrent vertebral conditions, the treatment options, and then lastly, anything to do with the outcome. On the right, you have some examples of what we would consider caudal tetrad, so A and B, and CAD would be a cranial tetrad. Nowadays, I find HASTE, so the sequences B and C being just a myelography type MRI, where the CSF signal is much more visible, to be very useful for this confirmation, and I think it is quite easy to recognize this difference. So for this, we just did a retrospective observational study, and the inclusion criteria were mainly SID diagnosed with an MRI and all the clinical notes being present, including the neurological examination information. For the MRI, we included T2, T1 as sagittal stairs. We localized the SAD in relation to the disc that was closer to it, and then we identify if there was a presence of concurrent vertebral conditions, and finally, if there was an associated syringomyelia, where we calculated the length and then the length ratio to L2 or S3, depending if it was cervical or thoracolumbar. Furthermore, we needed to include this Baltigrad sequence, which is T2 weighted thin slice graded echo base sequence on Philips machine, and which is great to really be able to reconstruct and then better appreciate the SAD conformation. But not only that, also for the syringomyelia localization was quite useful. And then we, depending on the tail, we would define as caudal and cranial. On the right, you have two MRI images where you can, again, appreciate how maybe in T2 was a bit challenging on the sagittal to see the conformation. And then when we reconstruct, was much more obvious that was a caudal tail. So for the treatment was either medical or surgical, and for the outcome collected, we just classify as improvement, static, and deterioration on clinical notes, available for the short term between 3 and 8 weeks, and for longer than 6 months, we would consider long-term outcome. For comparison, we use students' t-test and Mann-Whitney U-test for numerical and categorical variables, and then Fisher-Exact test, for categorical variables, and then we use logistic regression just to look for any predictor of outcome. For the cervical cases, so in terms of results, we had 12 dogs, so that was a lower proportion of the cases that we had. All of them had this cranial tetrad cervical SAD with the caudal syringomyelia present in all of the dogs. So all of them were caudal, but just in half of the ones that were present. And therefore, was not possible to do any further comparisons in this group. However, for the thoracolumbar spinal arachnoid diverticulum, we had 50 dogs, half of which were cranial tetrad, and the other half was caudal tetrad. And interestingly, we found a large proportion of them to have syringomyelia associated. So there was about 82%, so 41 dogs that had it there, and was always present on the opposite side. So if it was a caudal tetrad, would be cranial, and if it was a cranial tetrad, would be caudal. I hope this makes sense. So it was always on the side of major compression, to contrary to the side of the tail. And then what we found is that actually the caudal tetrad ones had a significantly longer syringomyelia, and also a significantly increased ratio as well, which makes sense. Furthermore, we found that there was a statistical difference between the short-term outcome between cranial and caudal tetrad conformation, which was kind of unexpected. And as you can see, the caudal tetrad ones, there was a larger proportion of dogs that have improved. So when we look into this with univariate analysis, we found that caudal tetrad thoracolumbar SAD had an improved short-term outcome, which after including also the length of the syringomyelia on the more multivariable logistic regression, also this still was sustainable, and only just the caudal tetrad, so only the conformation was able to predict outcome. However, the same was not obviously visible for the long term, and we need to take these results with a pinch of salt. We had a small number of dogs included, so 62 dogs is not a large number, and there is also a selection bias, so we excluded dogs that didn't have this more recent sequence, Baltigrad, so it was around 25 dogs. And finally, obviously, the available outcome was missing in some of the dogs, so 14 for the short term and a large proportion for the long term, so that were missing, and obviously that was also influencing the results. So the take-home messages would be dogs with thoracolumbar SAD can have a caudal cranial tetra conformation. I think that's really interesting. And also there is a high proportion of syringomyelia reported in this study. That caudal thoracolumbar SAD had a significantly longer syringomyelia, but also an improved short-term outcome was found with this conformation. Was not something that we were expected, but is something that we found still remains a bit speculative why this is happening. Maybe a different disease or a different disease process is difficult to know. And then we look into this condition in cats. So today, the main thing that we have is were just case reports. So we wanted to know what was the clinical presentation, diagnostic imaging findings, treatment, and outcome in a larger group of cats. Is considered a fairly rare disease in cats, and previous reports have mainly classified this condition as an acquired disease, so acquired to secondary to any disease that have made these cats to develop this diverticula. So the aims of this study was first to describe this large on a case series of cats, so a larger population, but also to compare if the presence of a concurrent spinal disease was associated with an SAD and see if there was a difference between these two groups. So for this, we have enrolled 7 referral institutions, so one in Belgium and the rest in the UK. We needed to have complete medical records and obviously the MRIs to review, including treatment and also outcome. We needed to localize SAD and, if possible, the presence of syringomyelia and SAD confirmation, given that we were already looking into that before. And also the outcome was fairly similar to the previous study. The statistical analysis was also very similar to the one to the dogs, so I'm not going to dwell much into these. And in terms of the results, we had included 21 cats, which is a fair number, considering that is a rare disease. The most prevalent breed, not surprisingly, was domestic short hair, and there were more males, so 62%, and most, so the median age was 80 years old, so were just like mature cats, let's say. And on the right side, you have a case where we suspect it was a primary SAD. We presume primary if there was no obvious underlying spinal disease or previous surgery that could have made these cats to develop SAD. In terms of the clinical presentation, very similar to dogs. So most of the cats present with ambulatory paraparesis, tetraparesis, and pelvic limb ataxia. Some dogs with, some cats, sorry, with ambulatory tetraparesis, 2 cases, and 1 non-ambulatory paraparetic, but also one, interestingly, with bilateral vestibular ataxia, which I'm going to explain in the next slide. No cat was reported to have spinal hyperesthesia on presentation. I don't know about you guys, but I always find quite tricky to know for sure if the cat is painful or is just being a cat. But yes, on the records, there was no obvious pain. And most cats were considered to have symmetrical clinical signs. The ones that didn't have were mainly on the posture reaction, so it was not so much detected on the gait. So it's not incredibly asymmetrical as we would expect for conditions such as FCE or NPE. In terms of the neuroanatomical localization, most of them were T3L3 myelopathy, C1C5 myelopathy would be for the rest, with one of the cat had this bilateral symmetric vestibular ataxia, having this quite cool C1 spinal arachnoid diverticula. Interestingly, only one cat, so 5%, was presented with fecal incontinence, with the SAD being at the level of T3, T5. And here is the distribution of the SADs. So the vast majority of them were at the thoracic level, with some at the lumbar level, so 3, and another 3 at the cervical level. most of them dorsally, apart from 2 cases that were ventral at L4, L5, and T5. The MRI features, so most of the cats had a cranial tetrad conformation, apart from 1 cat that interestingly had a caudal tetrad at the level of C2, which is not something that we have not found on dogs, and syringomyelia in 58% of the cases, where all the syringomyelia was identified caudal to the SAD, as on the example on the right, which is a cat that had this thickening of the ligamentum flavum and a protrusion and underwent the surgery there, and then subsequently has developed a syringomyelia with an SAD with syringomyelia later on his life. So further results, concurrent disease was associated in 11 of the 21 cats, being distributed the way that is here. So vertebral malformation, a previous fracture, disc herniation, previous amylomenectomy, or a vertebral epiphyseal dysgenesis secondary to primary hypothyroidism. Terms of treatment, but majority of the cats were treated medically with steroids, and surgery was performed in 8 cats with a dorsal laminectomy and endorectomy in the majority of them, apart from 1 that also had a titanium mesh applied, and amylomenectomy and durotomy in 2 cats. Interestingly, on the short-term outcome, we can see that there is a larger proportion of cats that were considered to have an improved outcome. So this is on the recheck follow-up. But when we look at the long-term outcome, things are not as great. Unfortunately, only available for roughly half of the cases, with a time frame from 11 to 36 months, where 8, so the large majority of them had deteriorated, with 2 recurrences at the same site. On the right side, there is an MRI just showing how a cat that had this primary SAD bilobed, dorsally located, had a dorsal laminectomy and durectomy, and recurred a few months, I think, yes, 21 months later. And yes, so only a few of the cats continued to improve, and 1 remained static. There was no statistical difference when comparing cats with or without concurrent disease in association with SLD, so the ones that we would consider acquired versus the primary ones. And again, a lot of the limitations with such as observational retrospective study is multi-center, so treatment protocols were not standardized. MRI machines were different between practices, so this would influence the ability to identify accurately the SAD conformation in the presence of secondary syringomyelia, the misclassification of primary SID or presumptive primary, because we couldn't rule out completely a minor vertebral anomaly or fracture or a previous incident that has happened on the central nervous system around that area. And finally, the small number of cats with long-term follow-up information, which was mainly obtained by telephone interviews, which is rather subjective. Take-home message from this paper: so nearly half of the cats were didn't have any underlying spinal condition associated with SAD, which is the first time this has been reported. So previously, these case reports were mainly acquired ones. There was no difference between primary and acquired SAD in terms of the presentation of these cases for signalement treatment or outcome. Most cats were treated successfully with surgery for the short term, but actually for the long term, a large proportion has deteriorated regardless of treatment. So feline SAD is uncommon, but could be considered in chronic, progressive, symmetrical, non-painful myelopathies, particularly if male and a previous spinal pathology or surgery has been identified. So still a lot of questions left to answer. I hope you have some for us to discuss as well. But I think the central point is just really to accurately distinguish between congenital and acquired forms of SAD presents an important challenge. And while we cannot really while we are not able to do that, it will be very difficult to determine what would be the most useful treatment, and also what would be the best outcome associated with that treatment, because then we would have a better idea what is this underlying disease. So yeah, I just included a cool durotomy just with a fountain which makes everyone excited in surgery. And also just included here a bit of more questions in terms of what we see on the human counterpart. So we call them spinal arachnoid diverticula. Majority of them, I believe they are, but can we have maybe some cysts as well as seen in human medicines? They have these web ones as well described, which I think are very, very similar to the ones that we see in dogs and cats. And the pathognomonic clinical sign would be this, what would they call a scalpel blade sign. This is a patient that had dorsal laminectomy and then durectomy, and this is 7 months later and is considered curative. And then furthermore debate, can this be also then leading to meningeal fibrosis constrictive myelopathy as we see in pugs? I don't know. I just leave the question in the air, just to acknowledge, obviously, all the people that help me and our team. I wouldn't be able to do it without all the co-authors, RBC, and also my colleagues here at Edinburgh. I just want to thank everyone for these multiple places and say thank you very much for hearing me, and hope you have some questions now for me.
Thank you very much, Joao, for this presentation. Well done for managing to pull together so many cases. Always, carry more weight, obviously, to have a study on larger number of patients. There is a few questions for you. First one is from our friend Alexander. Thank you for these two excellent study and your talk. The first question is, I'm going to start by the end, actually. Do you have an explanation for the mechanism of syringomyelia when it is located caudal to the lesion? Or cranial to the lesion, actually.
Yeah, so it depends what is the conformation. So that's what I was explaining. So if you have a caudal tether, so with the tail, let's call it the tail, so it's easier. The tail going caudally, all the cases had the syringomyelia located cranially to the site of most compression, while the other way around was what we found for the cranial tethered. Why is that? Well, looking into a bit more in human medicine, they put a lot of emphasis on syringomyelia, on spinal arachnoidal web. The reason why is that they think that the clinical signs that are most common is neuropathic pain. And neuropathic pain, they think, is secondary to this syringomyelia formation. Later on, human patients would develop myelopathic clinical signs. So the mechanism, I would believe, that is the same as we see in other cases. So CSF disturbances, maybe the pressure that is applied, making the width of the central canal shorter, and the pressure increased, which therefore leads to this widening of the dorsal part of the central canal, and then the formation of the syringomyelia. I don't know. I'm just speculating here.
I think that it's probably what Alexander means is with regard to the relation of what we think being the caudal flow of CSF, the cranial caudal. It's true that it's difficult to understand why this will happen.
Yeah, that's a good point. I don't know, and I cannot explain why we see is different to the direction that we would normally expect the CSF. Yes.
I mean, even if the flow is not only equal like that.
Exactly.
Mostly caudal.
Maybe it's just a turbulence that happens at that level. I don't know.
Yeah, and the other question was about I don't know if we got the answer, to be honest. Neuroanatomically, why dog develop fecal and urinary incontinence depending where the lesion is. But I think we've got an answer to that.
The very truth is that I don't know. Obviously, we think that is the sensory component that is mainly affected, and therefore fecal and urine incontinence can see in these cases. But then why do we see more in thoracolumbar and not so much in cervical? I'm not sure. I mean, I know what I've read in human medicine is fairly similar. I think even the terminology that we apply to it, incontinence probably is like more of a dysfunction that is felt in humans. So you have this inability to control the stream of urination, which sometimes we see, especially with feces. So the dogs they have the urge to defecate, but they are not able to stop it. So I think it's more for the sensory component rather than being an incontinence. I hope this makes sense.
Yeah. question from Fernando, with a regular on this page. SAD have a worse outcome in pugs. I think we've all, will agree with that. I mean, do you approach them in a different way in terms of stabilization or not?
I think more than, it is my answer to it. I don't know if it's right or wrong, but more than just seeing the breed of the dog, I tend to see each SAD differently. It's different to have an older dog with an SAD and loads of concurrent vertebral malformations to have a younger dog that has a SAD and no vertebral malformations at all. So being a pug, normally we would be biased to just looking into these vertebral malformations a bit more closer. And what has been reported, obviously, previously is that they have a higher chance of recurrences and they have a worse prognosis after a year of having surgery. So typically, I would say for pugs, yes, I would stabilize, but I try to remain, to evaluate each one of the SAD cases, because it may happen that if it's one of the congenital ones or primary ones in a very young pug, you may not need to stabilize if there is no obvious signs of vertebral malformations or instability, at least on imaging.
Another question, how much the dura you remove during durectomy? I mean, basically, how do you manage them? You know that there is different technique, durotomy, durectomy, marsupialization. What do you prefer? And maybe you can share with us why you prefer one than the others,
Yeah, I think this is still a big mystery for all of us. And I think, I'm no expert whatsoever about this disease. I've just really love it, but I've done a few, but I still think we need to learn more what is the origin of it and what is the best surgery to treat it. And why I say that, mainly because of the last point of my slide. In human medicine, is very different if you have a cyst, if you have something that is more like a cyst and a web. I believe that most of the diverticulums that we have is more of a web. And just as a comparison, so spinal arachnoid web in human medicine would be regarded as an excellent outcome to be curative if you do durectomy and release all the web and just relieve all the pressure that is caused by it. While, for example, if it's more of a cyst, a shunt could be considered, for example, just because of that continuous production in there. So in conclusion, on most of my cases, I would do a durectomy, and yes, I will do as well duroplasty with some swine intestinal, not some mucosa, so some artificial dura mater, the same as used in humans. If this is the right treatment, we are yet to know. I think is what we have as evidence at the moment, but probably first we need to know what we are treating, if they are all the same or if they are different.
Well, we wait to see if there's any more question. Just a comment. I mean, from what we've been seeing, on reporting, MRI, there is obviously the obvious SAD where it's a teardrop shape, and I think everyone will call it the same. On the other extreme, there is the constrictive myelopathy, and in a lot of this, though, you can see, the at least the dural band crossing the subarachnoid space, and often we have contrast enhancement. But then we got the one in the middle where, it doesn't look really like a teardrop, but there is some feature of the constrictive myelopathy, which is you can see the meningeal enhancement, and you can see some or sometimes multi-pocketed area of subarachnoid space dilation and compression of the cord. It really posed the question, should we routinely, on any case with subarachnoid dilation, do post-contrast, and especially do them with fat saturation? Because maybe some of them are not congenital, maybe some of them are acquired, and there may be a different form of constrictive myelopathy. I'm just wondering, because we got really these two. Initially we described these two different conditions, but we got a lot in the middle.
Yeah, I agree completely. I think the spectrum is where we are in some cases. So it's not like a clear one or a clear other, and there is this spectrum all in between that is much more difficult. And I think, yeah, we hopefully will be having more coming from it, and just like looking into it, not only from an imaging, but also, just from a surgical point of view. And hopefully we'll have more information, coming out soon.
I think doing contrast on all of them would be really useful to try to stratify them. And we can take maybe a couple more questions to finish. Hi, Joao. I don't know if you know this Faye. I think I know you. Hope you're well. If you mentioned there have been a few mention of the septum posticum in the last publication, do you think it could be involved in the pathogenesis of both cranial and caudally tethered SAD?
Yes, great question. Thank you, Faye. I think it may have a role, but most of all, I think so. First of all, septum posticum has been implied in the formation of SAD for a while, but has now been very well proven to exist by Professor Vicente Gil, with his neuroanatomy book. It has like some really nice images of it, especially at the level of the thoracolumbar level. So it's not so much existing on the cervical region as evident, and especially as like a dorsal band. Yes, I think it may have an implication on the caudal cranial conformation, but if it's the existence of it, I'm not too sure. And also, it still remains the question: why do we have ventral located SADs in some cases? Difficult to explain. Hence why I think, in my opinion, maybe cervical and thoracolumbar SADs are not the exact same thing. Also, the populations of dogs that we see are not exactly the same. So it may be that they are different in the septum posticum, but that has a more of a place on the thoracolumbar ones.
Would you mind just reminding, for those who don't know, what is it, the septum posticum?
Yeah, so it's, I hope I say this right. So this is a ligament that attaches from the dura mater to the spinal cord, and then even on the epidural space on the dorsal portion. Some dogs have these dorsolaterally present ones. Some dogs have just one midline one, and it's just for stability of the spinal cord. Otherwise, would be floating on the ventral canal and just banging everywhere. So it's just to keep everything in place.
Thank you. The last question, and then we let you go. Do you find sign of intramedullary edema or contusion very often in the local of the compression or adjust? I mean, where do you usually find the change? I have to say it's not really contusion, but do you find it at the level of the compression or more adjacent? Does it make any?
Yeah, so I think it's more adjacent. I think is more like, where is that syringomyelia present? I must say that our study identified in a much larger proportion of cases than previously. I think that the most was Sarashiva paper, which reported in about 50% of the cases. I mean, 80% of the cases is a large proportion of dogs to have these changes on the spinal cord. I have empirically that experience to see a lot of dogs with these changes, and the influence of it, I don't know. I'm not too sure.
Very good. Thank you so much, Joao, and I leave Simon for the last few words.
Yeah, thanks, Joe. That was an excellent presentation, particularly getting so many cats together. That is very impressive, really impressive, and adds to the literature. So yeah, thanks for that. Thanks to everyone for tuning in. Thanks again to Hallmark for sponsoring these sessions, making them possible. These recordings, or the recordings of the webinars, are actually going to be available on our website, which is web-vetneurology.com. So go ahead and visit that and listen into the webinars and podcasts. That's it from us. Join us again in May for our next Journal Club. And thanks again to everyone involved.
Goodbye.
Thank you.